wanted this video to be a little bit more relaxed, so I am laid on my bed. Um, so my first spoke placement was at an endoscopy unit, which was at a less acute site. So we only really dealt with gastroscopies and colonoscopies. I did have the opportunity to go off to a more acute site to look at GI bleeds and emergency colonoscopies um, or gastroscopies, but I felt like where I was enough for for the first year. So a couple of talking points that I want to talk about is the role of the nurse during the pre and post procedural care, infection control, patient safety measures, and sedation monitoring. A couple of the good points that we'll talk about is the structured environment. It was a great learning opportunity for me in regards to anatomy and equipment, and it was quite a fast-paced, team orientated. So for me, what I understood at the time was absolutely nothing about endoscopy. And the role of the nurse, it was a nurse-led unit, so that meant nurse admissions right through to nurse discharges. So you'd have a team that were in admissions, a team that was in recovery, and a team that was in surgery. So you patients would have their pre-assessments ready for either their gastro or colonoscopies, and they would be booked in by the clerk, and they'd wait. They'd come in, the nurse would go through the pre-admission details and the pre-admission form and cannulate the patient if they had opted for sedation. Now, I don't know how it will be when if any of you guys get an endoscopy placement, but the trust that I work for, they use buscopan, midazolam, and fentanyl for endoscopy sedation. And it was really important that when the patients came in, they were asked if they had someone to get them home because they couldn't drive. So once we'd gone through the pre-admission forms, we'd take a set of observations to make sure that the patient was clinically well, and then would get them changed into a gown and then led over to the bed where they would get on and wait to be called in to the surgery. While that was going on, you had the surgical team who would prepare all the medications that they would need, i.e. the fentanyl, midazolam, buscopan. They'd make sure that the endoscopy units were correctly fitted and ready to be used, and that they were safe to be used, and that they weren't pierced or open to the elements because it's a sterile unit. The place where I worked, we didn't really have endoscopic consultants. It was nurse led. So we had endoscopic nurse specialists that performed the endoscopies. When you're into the surgical room, patient is brought in and then the who checks are done to make sure that you've got the correct patient. And then the patient is obviously sedated, ready for the procedure. Now, at any point, the patient is told that they can stop the procedure just by saying stop if they feel uncomfortable or if they want to stop at any point. Once the patient's had the surgery or the endoscopic diagnostic test done, patients then wheeled out into recovery where they were generally given tea and toast, given about 15 minutes to recover, and then sent on their way. It was a very fast-paced environment, one in, one out. Some good points for me is I thought it was very structured and I thought the environment flowed very well. So the minute the patient came in, you were made aware, they went straight into the assessment room. Assessment was done, they were changed into their gown, popped onto a trolley ready to have the procedure done. Procedure was done, and then they were out for monitoring. If there wasn't any adverse reactions or any adverse things that needed to be discussed with the patient was generally in and out within 45 minutes to an hour. So the way it worked for me, the trust that I worked for, you worked 9 a.m. till 5 p.m. So within that space of time, you could see 8 patients, sometimes 9 if it was a very quick procedure. For me, it was a great learning opportunity about the anatomy of the gastrointestinal tract, your colon, intestines, kind of everything within your abdomen. Really, really good for me to learn about that. And the staff they were really, really, really good at teaching. And when you would go into a procedure, you'd generally find that endoscop would want the student stood by them so they can watch and explain what they're doing. And then you kind of got to learn the anatomy of the large intestine as you went up. It was really good for me. Again, it was fast paced, but really team orientated. Everybody wanted to work together to get the best that they could for that day, try and get all the patients seen. So for me, it was really good about timekeeping, understanding that things can be fast paced. And then we did have one day where we had quite an unwell patient, and it was good for me to see how different drugs can kind of cause different things. Some of the challenges I felt at this placement was that it could feel quite overwhelming at times. And that was due to the technical equipment that was being used. I'd never seen endoscopy equipment before, I'd never seen endoscopes, I'd never seen the equipment that was being used. But I asked lots and lots of questions, and by the end of those 2 weeks, I was setting up the endoscopes ready to be used by the endoscopic nurses. Another thing as well, I'm very patient orientated. So for me, it was quite limited patient interaction unless I was in either the assessment or discharging area. In the surgical area, the patient's generally sedated, so they don't really talk to you much. They're quite sedated, so they're not very talkative. If I was to look back on this and reflect, I would probably say that some tips that I would want to give any first year students going into an endoscopic unit is ask lots and lots of questions, understand the equipment, so the scopes, and understand the sterilization process, how they get sterilized and how they come back, and how what you should be checking for to make sure that one, the bag hasn't perforated, and two, there's no water in the actual scope themselves that could lead to legionnaires or anything like that. And another big thing is shadow the nurse, like during from beginning to end, and look at it as holistic learning. So from admission, understand the admission processes, going into the surgery itself and understand the surgical process and things to look out for, what you need to monitor, and then recovery slash discharge. All really good areas for you to learn, and that will have you instead when you go into your second and third years. So my next clinical placement, spoke placement, was a dialysis unit. And dialysis basically treatment for patients with chronic kidney disease through a hemodialysis machine. And it takes volume away from the body, excretes all of the nasties out of the blood, and then kind of cleans it, pops it back in, but takes some water weight out because obviously people with chronic kidney disease sometimes don't urinate, so they can hold a lot of water weight. And the idea of dialysis is to clean the blood and take away some of that water weight. So this was for long-term patients that had chronic kidney disease and were in kidney failure. And it was really good for me to understand the importance of fluid balance, electrolyte balances, and access care, looking at things like central lines or fistulas. And it's really good as well in the MDT approach, looking at the involvement with renal nurses, dietitians, nephrologists, physios, OTs. It was really good to see that kind of interdisciplinary work in. And understanding, renal nurses specialize in hemodialysis or kidneys, and they're so knowledgeable. So I was kind of in awe of them, and I wanted to soak up every little bit I could. Obviously, again, it was only a 2 week placement, so there's only so much that I could do. Some of the good points for this for me was that it had a repetitive nature, so it meant that I was able to build an understanding quite quickly of the hemodialysis machines, understanding how the lines were connected, understanding the fistulas and how to gain access. Obviously, as a first year student, I wasn't able to do venipuncture, which meant that I couldn't actually physically pop the lines in, but I could observe and see what the nurses were doing. Um, it was really, really interesting. And to see fistulas as well and see how some of them could could bulge and be quite large, and others could be really well maintained. And the opportunity to see compassionate long-term care for patients that are having hemodialysis. And I think what kind of shocked me was that diabetes, having come from a diabetes hub ward, and how that relationship with diabetes can lead to chronic kidney disease was really interesting as well, to link those as a comorbidity. Some of the challenges I faced, particularly coming from a busy hands-on environment, is I was very much observational at this bespoke placement. I couldn't really do a lot because it was a private company. It wasn't the NHS, which meant that I was very restricted in what I could do. So it was quite slow paced. So at times I did get bored because obviously once the patients are connected, hemodialysis runs for 3 to 4 hours, and then it's just maintaining the patient, making sure they're comfortable, checking their observations, and making sure they're not deteriorating while on the machines. And 9 times out of 10, the patients would just watch television or sleep. Another thing as well was the complex medical histories for patients. So sometimes it wouldn't just be one thing. It wouldn't just be chronic kidney disease. It would be, like I said, diabetes or alcoholism, drugs, anything. You had people from all sorts of walks of life. So that was quite a challenge sometimes, being able to make sure that you could give the care to that patient and then make it individualized and from a holistic background. If anyone ever gets a dialysis unit for any of their spoke placements, some tips, having reflected on it, would be to familiarize yourself with common renal medication, and understand the anatomy of the kidneys and the renal system and how that works. and obviously be hands-on, ask to monitor or observe the lines and the fluid calculations, and be part of, popping the patients when they come in on the scales, weighing them, and then getting them back off. So you've got their pre dialysis weight and then their post dialysis weight, because it's really important that you should be taking out however much has been prescribed by the nephrologists to make sure that they are back within their weight. And again, to understand when not to put a patient on the dialysis machine if they're unwell. Patients will be very rigid because it's their routine. They will know the best way to get access. They will know how comfortable they are, and you need to be, you know, compassionate with that. Some patients may not want to talk to you while they're on dialysis, just want to get in and out because it can be a hindrance. It's 3 to 5 times a week they come in there and doing that, depending on the chronic care that they have for the kidney disease. So it can be quite difficult sometimes to understand what patients want in regards to communication, or if they just want to be left alone. So it's just about being observant and being willing to understand that that's just the way it is. My next spoke placement was changed last minute. So I was meant to go to a community learning difficulty alternate field placement, but because the staff came down with a like flu virus, they were all off sick. So I got moved at the last minute to a gastrointestinal ward at one of our acute sites. Now, gastrointestinal ward deals with patients with things like Crohn's disease, colitis, liver failure, GI bleeds, or just generally gastrointestinal and abdominal issues. So it's very vague, very diverse area to be in, and I learned a lot actually. And I'll cover here some good points, some challenges that I had on this particular ward. Some of the talking points for me is that I learned a lot about NG tube care, stoma care, and nutritional support, i.e., different ways of enteral feeding, peritoneal feeding, things like that. I got to observe um, quite a few signs of deterioration. So we had patients in that were very clinically and acutely unwell, and were kind of on that cusp of being sent to intensive care. I got to see GI bleeds happen on the ward. I got to see um, stoma prolapses, just things that were quite not very nice to see, but were really good from a learning standpoint. And the emotional toll of chronic diseases and illnesses on patients, because some patients that come in a gastro ward are quite chronically and clinically unwell. And I think what surprised me the most as well is how many alcohol dependent patients you have that come into a gastro ward. So that was kind of a sobering experience. Excuse my pun, no pun intended. But it was very sobering to see what alcohol can do to patients' bodies from chronic use. Some good points for me was that there was a variation of conditions and there was a lot to learn. And I always felt like I wanted to go back and learn a little bit more. And it was good exposure to bodily systems and acute clinical care. However, this ward was actually quite challenging in how I was treated as a student and a person. The staff were quite difficult to work with. It can be a very busy and complex ward to work on, so obviously I was very much out of my depth, but I was always asking questions and willing to work, willing to learn. High dependency needs at times for some patients were 2 to 1, 1 to 1, and that was quite difficult to manage because obviously staff shortages. I had a lot of difficulty with experiences in regards to staff attitudes. There were mixed attitudes towards students from all years, so that's year one right through to qualify in year three. I felt undervalued and dismissed all the time, and I felt like nurses didn't want first year students, so they put you with the healthcare assistants, which is absolutely fine because you can learn loads, but they just weren't willing to allow you to do anything clinical or to get any of your proficiency signed off. And I remember that I went to the PPFs, which are our like placement facilitators, and I said, look, I'm not getting any kind of knowledge or experience. And then what happened from there is I had a meeting, and then I just decided that I wasn't going to go back for my last 2 shifts because it was just far too toxic, and I wasn't going to, be paying for my nursing degree to be treated like that. And then having reflected on that, this ward impacted my confidence, and it took me a little while to regain that. So, you know, I got a little bit of imposter syndrome after this ward. I kind of lacked confidence in my ability because I wasn't allowed to do much. I always felt like I didn't know anything. I wasn't able to do the bare minimum. So that kind of took its toll on me. It took me a little while to get over that. So reflecting on how I kind of addressed the situation with the staff and the way that they treated me, as I spoke to the staff I pulled them aside and quietly had words with them. That didn't work, so I felt like I needed to escalate this to the PPFs. When I felt like the PPFs didn't mitigate very well, I took it to the university and explained that I wouldn't be back and I would make up those hours back on my hub on a progression week. I just felt like it was not worth my mental health or my emotional health to um, be treated like that. And I apologize if this offends anyone, but 9 times out of 10, as a male, you'll hear this a lot that you will be favored over the female nurses because they're trying to encourage males to come in so they you promote quicker up the band. Now I don't agree with this whatsoever, and I really do not agree with this. People will get promoted on their candor, their competence, and how they are their mannerisms. And I've worked with some fantastic female nurses that are in high positions because they're very good at their job. And I've worked alongside male nurses that are in high positions because they're very good at their job. But some people are stuck in their kind of old ways, and I got treated, as an outsider because I was male. And females will get this on wards that are male dominated, especially when you go into medicine. I've seen some female medical students being treated quite poorly. Um, and this was my first and only experience, mind you, in my first year where I was made to feel unwelcome and not part of the team. But I just tried to be graceful, tried to be professional, and then in the end, I made the decision that benefited me because I just didn't want to put myself through any emotional mental stress. I leaned quite heavily on my academic assessor for support, and then having looked back on this, I learned to advocate for myself, and then maintain my motivation. So even though I was off for those 2 days, I kind of did some self-directed study on the gastrointestinal tract, gastro diseases, chronic diseases, just to keep myself kind of so that I was learning. If I was to give anyone any tips on if you had a gastro ward, was to just throw yourself in the deep end. There are so many spoke opportunities within that ward. You know, I wanted to go off and work with the alcohol and dependent team, look at like alcohol relations. Again, they wouldn't let me go. I wanted to go off and do a day with the Crohn's specialist. There are many things that you can do to expand your learning, and you don't have to stay on the ward. You can get spoke experiences off with other members of staff or other departments. And just, I think confidence with stoma products and communications around them. So I found myself being quite shy because I'd never seen a stoma before. So it was really important that I kind of wish, having looked back, that I kind of leaned into that a bit more and was willing to kind of get hands-on involved. And I think, this ward, even though I had a difficult experience, I did learn a lot, and I learned, and I still carry some things that I've learned into second and now going into my third year. So I did enjoy some of the stuff that I was learning, and I just had wished the staff were a bit more receptive to students on that ward. So my final spoke opportunity that I had was working on a stroke rehabilitation unit, which was a step down from the acute stroke care wards that we have within the trust that I study in. And what I liked about this placement is that they focused very heavily on recovery and re-independence of patients. Some of the talking points for this are that they had really good MDT working. So you had your neurologists, you had your stroke rehabilitation nurses, your physios, OTs, speech therapy, all within this one area. And their sole focus was to rehabilitate that patient as best they could to either have new baselines or return them back to baseline to prior the stroke. What I liked was the independence of communication aids and the holistic person-centered care that took place here. And I liked how they had rehabilitation goals to motivate the patient, and they were small and achievable. And when you look at reflection, you look at the Gibbs model, and you can kind of see how they made really good smart action plans for the patients and made them achievable, time bound, and easy to achieve. So it made the patient feel like they were making those small recoveries. Some good points for me was I was only there for 2 weeks, but I got to see new patients admitted, and I got to see patients being discharged back home for continuation of care without patient physio or OT appointments. So that was really good for me to see like your admission process and your discharge process, and see how patients came from A to B to discharge. Um, and it was just great communication skills that I developed, as in learning how to alternatively communicate with patients. Some patients that had certain strokes weren't able to communicate or couldn't quite get the words out. So if they were trying to say, hello, my name is, sometimes they would say apples, bananas, and pears, or they wouldn't be able to say the sentences. So we're trying to understand other ways to communicate with the patient that wouldn't cause them to get frustrated, which, it will happen because if you imagine we're all human at the end of the day, and if we're not able to get across what we're trying to get across, that's going to be quite infuriating and frustrating. Some of the challenges is this was quite an emotionally heavy ward at times because you would get to know the patients because it was quite intimate, and you could see the patient grieving their previous ability to where they are now and trying to accept and understand how to move forward with their lives, having had sometimes life altering strokes. Some were quite minor, others were like little TIAs that had caused some problems that had led to another stroke or things like this. I mean, they're all terrible, and they're all awful. But to see some of the patients kind of going through that grieving process could be quite hard to deal with, and you end up finding yourself kind of questioning your own mortality, but then realizing how lucky you are. Some of the other challenges as well was that the fact that it was a lot slower paced than the acute. So what I liked about this ward is again the staff here were lovely towards students and they wanted you to learn. And being a first year student to go on a morning medication round is quite unheard of, really. But I was working with a sister. I won't mention names, but she was this beautiful Polish woman, absolutely just beautiful throughout. And she took me with her from morning right through to the evening. And I learned how to document, how to do medication rounds, what kind of things to do with the patients, as in like initiating care plans, just basic nursing care, but I got to learn how to do it all for the first time. So this was kind of where I learned to do all of the documentation. I mean, I had learned on my hub placement and I was going to be going back there after this, but to have that kind of experience on a spoke placement was fantastic because my learning opportunities just continued to go up and up and up and up and up. It was just brilliant. Some tips for me, to anyone that may be going into a spoke rehabilitation ward or a stroke ward is you need to learn how to use manual handling equipment such as hoists, stand aids, mobility aids, and you need to be competent and confident in using them. And then just practice patience because it's quite difficult sometimes, having gone from the acute where it's extremely busy to then go into somewhere that's a little bit less acute, um, and it's a little bit of a slower pace. And sometimes the patients can be quite difficult to communicate with. So just practice patience and just observe other nurses and how they encourage independence or how they communicate with patients. Because that's really important, learning off of your supervisors and mentors, because their knowledge is invaluable because they're going to have been where you are and they're going to have learned these skills that you can learn from them while you're in this position. So you're in a really lucky position to do that. I was there for 2 weeks. And another thing that I can give you a tip on is abbreviations. I remember having a handover and they were using abbreviations like EDD, and I was like, what on earth is this? Estimated discharge date, and like left infarct, right infarct, and I was like, what on earth is this? Cabbage, and I was like, what's this? So try and learn a little bit about the ward that you're going on. And I don't know how it is for anyone else's universities, but we have like an ARC system where we get our placement and we have like a little box that comes up with useful pre-reading and then some information about the wards. And some wards will give you a ward information booklet which you can download, have a good look at. And sometimes they give you like abbreviations to kind of revise and learn before you attend the ward. So I apologize sometimes about the quality of my videos. I'm still trying to learn how to make them a little bit more inviting, make me sound a little bit less baritone and boring. But some general tips for you first year students that are either going into your first year or are kind of in the process of doing your first year or even coming to the end of your first year is keep a small notebook with you, like an A6 size notebook, to jot down some conditions that you see, drugs that you see, and procedures that you see, because it's invaluable to kind of look back and then you can have like a little notebook with you to jot things down quite roughly with, and then have one back home that you can kind of write it a little bit neater in so you can understand it. Something, having reflected now, coming to the end of my second year, going into third, is always ask why. This is the only way that you're going to learn as to why you'll do something. And then as you get into your second year, you'll start to understand about evidence-based practice and understanding why we do things. And once you can grasp the why, it makes things a lot more easier to understand. So, you know, if someone's doing something, for instance, for me on the stroke ward, she was using an NG tube to feed, and then she was holding it up like this and allowing it just to free flow in. And I said, well, why do we do that? And she explained why we do that and why we don't push. So that, again, just ask, because if you don't ask, you're never going to know. Wear comfortable shoes. Like, you'll hear this a lot about shoes and footwear. Make sure they're comfortable, because you're going to be on your feet for 12 hours, maybe less, but 12 hours is kind of the norm. And it's just, if you've got really uncomfortable footwear, it's so uncomfortable. So I wear compression socks because I'm petrified of getting leg ulcers. So I make sure I wear them if I'm on a 12-hour shift and I know that I'm going to be on my feet a lot. I just wear some cheap Amazon compression socks. Make sure that if you are going to get some compression socks, that you measure, make sure you get the right size. Eat before, during, and after your shifts, especially if you're on a surgical ward or a theatre ward, because it's quite difficult sometimes when you've got long prace theatres. So just make sure you keep yourself hydrated. And something that I do now, having been second year into third year, is reflect after every day. So every day I reflect to see what I've learned, how I feel, and how I feel about going back to that placement. And I keep a little journal, which really helps me kind of just focus on what I'm feeling and process those feelings. And I'm not teaching to suck eggs, but just always thank staff if they give you an opportunity to learn something new, or if they treat you with respect. Just thank them, because you are a guest in their department, and it just doesn't go a long way to be polite. So thank you very much for watching my video. If you can pop any comments in about your spoke placements, where they were, if there's anything else that you'd like me to do a video on, or if you have any questions, please pop it in the comments, because I like to try and talk to you guys and communicate. And the next video will be looking at some of the theory stuff behind university that I did in my first year assignments, and I'll probably talk about a little bit of burnout that I experienced towards the end of my first year, where I just really struggled with motivation, and how I overcame that.